All right, great. Well, thank you guys for taking the time out of your day to join us today. I hope this is going to be helpful. Again, I'm a family medicine physician in the Stone Oak area. I've had an area of interest in diabetes for about 20 years now. And for a short time in the past, I ran a diabetes clinic and continue to see lots of diabetics, both type 1 and type 2, as well as doing some of the more advanced things like insulin pumps and continuous glucose monitoring. So today's topic is really one that is just going to be a broad overview on diabetes. We're going to hopefully give you some good what you need to know about diabetes and give you a good overlay to describe the disease and some of the basics of how we think about treating it. And then obviously we'll have some time for question and answer toward the end, as mentioned earlier. All right, so first, the question now obviously is, what is diabetes, right? There's actually a lot of confusion about that. So I tried to be fairly objective here and to show you the way we think about that on the clinician side. And so you can see that diabetes, as you know, is elevated blood glucose beyond normal values. So what are normal values and how do we look at that? So that can be defined a couple different ways. One is any fasting blood sugar greater than 125, so 126 and greater, meets the criteria for diabetes. By the way, a normal blood sugar that's fasting should be under 100. So between 100 and 125 is what we would call pre-diabetes, or what we also might call impaired fasting glucose, or IFG. But diabetes will be 126 and greater. And again, fasting is usually defined as about 6 to 8 hours with no food intake or calorie intake. Of course, you could have water, coffee, diet soda, and because they don't have calories, that would not impact your glucose. Another definition is any glucose greater than 200. So that could be at any time of the day, regardless of when you ate or what you ate or even how much you ate. So a person's blood sugar should really never be above 200, no matter what they've eaten, even if they've eaten poorly. So if you have friends or family that maybe do a random blood sugar check, anything above 200 would be considered or concerning for diabetes. And then last but not least, we also have a lab test you may be familiar with called the hemoglobin A1C. This is a lab test that is run by your physician or your provider. And normal value in America is about 5.2. Pre-diabetes is 5.7 to 6.4. And therefore, diabetes would be anything higher than 6.4, so 6.5 and greater. Those A1Cs are actually now available over the counter in the pharmacies. They're about $10 to $15 a test. And so if you ever wanted to get one yourself, maybe you didn't have access to a provider at the time, or maybe you were in between visits and wanted to see how you were doing, you can get these now yourself over the counter. They are not covered usually by insurance, but of course we encourage you to follow up with your primary care provider at HealthTexas, and we'd be happy to run this test for you if this was a concern. The next value next comment that we often think about is, okay, now that we've defined what elevated blood sugar is, what is the difference between type 1 and type 2 diabetes? And this is also a question that a lot of people get a little bit confused on. So I'm going to hopefully try to answer this for you moving forward. So first, let's define type 1 diabetes, because it turns out that if we understand type 1, anything that is not type 1 kind of falls into the category of type 2. So type 1 is really a condition in which your body's immune system attacks cells that make insulin in the pancreas. Those are called beta cells. And that results in the destruction of these beta cells, which can happen either very rapidly or very slowly, and ultimately leads to a low level of insulin or no insulin at all. And so this is a very specific diagnosis you'll notice. And as I mentioned earlier, if you don't have this diagnosis, then you have type 2 by definition. And the way this is done in the provider's office is that your provider can run a few different tests. We can actually test for these antibodies in type 1 diabetes. And so we run those tests. And if your antibodies are positive, then by definition, you have type 1 diabetes. And if they're negative, then you do not. We also often will run an insulin level at this time if we're looking into this, but do realize that even low amounts of insulin in the setting of a negative antibody does not mean that you have type 1. So again, antibodies are what determine whether you have type 1. And again, type 2 would be everything else. So while most people with type 2 diabetes have high levels of insulin, some people can have levels of insulin and they're still a type 2 if their antibodies are negative. So that's the fundamental difference, and I hope that helps between type 1 and type 2. And by the way, once you become a type 1 diabetic, you will always be a type 1 diabetic, so to speak. And if you were diagnosed with type 2 diabetes and that diagnosis is certain, usually you will not become a type 1 diabetic later in life. All right, so I started to describe this briefly, but I wanted to just kind of differentiate some common characteristics between type 1 and type 2, because again, there tends to be a lot of confusion here. So as I mentioned, type 1 are these people with diabetes who have antibodies against their pancreas, and usually their insulin levels are fairly low, or they may dwindle to being non-existent over time. However, it is important to know that while we treat these people with insulin, they can continue to make insulin for many, many years, sometimes even many, many decades. And we now know too that some people can have these antibodies present for many, many years, even decades, and actually still have normal blood sugar. So even though they have these antibodies and their beta cells are getting destroyed, they are still able to make enough insulin to support normal glucose for a long period of time. But at some point, usually their insulin levels fall to a level that is insufficient, and they begin to then have high blood sugar and have what we would call type 1 diabetes at that point. Traditionally, type 1 diabetes has been seen in younger children. Matter of fact, when I was in medical school 20 years ago, we referred to type 1 diabetes as juvenile onset diabetes, because we thought that all type 1 diabetes occurred in younger children or young adults. But it turns out that is not the case. We now know that some people can develop type 1 diabetes in adulthood, and sometimes even late in adulthood, in the 5th, 6th, or even 7th decade is possible. So it doesn't have to occur, or at least initiate, in a child. Also, because the primary problem is that people are not making adequate amounts of insulin, traditionally we will need to treat them with insulin, and oral medications are generally not effective. Now, it is true, by the way, that sometimes people are misdiagnosed. A person, particularly an adult who develops type 1 diabetes, they may go to their doctor and their doctor may not realize that they're type 1. They may assume that they're type 2 and begin them on oral medications. And then oftentimes these medicines will work for a little while, but if they begin to not work, then the doctor or the provider may go back and decide to screen them for type 1 diabetes. And obviously, when that is found, we usually will transition them off of the oral medicines and onto insulin replacement therapy. Type 2 diabetes, on the other hand, which many of you may be familiar with, usually has, as I mentioned, high or certainly normal insulin levels most of the time. And that is usually due to your body becoming resistant to insulin at the receptor level or at the cell level. Insulin is a hormone that basically does many things. And one of the things it does is it allows glucose to enter from the bloodstream and go into the cells of the body so the cells can use that glucose for energy. If insulin is not working effectively, then the glucose is trapped in the blood sugar and can't get into the cell. So the high blood sugar actually damages the body. And at the same time, the cells that need the glucose for energy usually are starving for energy, and that can be a problem as well. So again, insulin resistance, insulin resistance is typically the fundamental problem with type 2 diabetes. And if you measure insulin levels in a type 2, they generally run fairly high. The body is trying to make more insulin to overcome that insulin resistance. However, it is possible some type 2 diabetics, as I mentioned earlier, do have trouble producing adequate amounts of insulin. It's also true that if a type 2 diabetic is insulin resistant and has high levels of insulin for long enough, the pancreas can kind of get worn out, for lack of a better term, and begin to produce less and less insulin over time. So oftentimes for patients that have had diabetes for many years, often many decades, we'll see that their insulin levels do begin to fall and they become insulin deficient over time. Now remember that when this happens, we often will transition type 2 diabetics to insulin therapy, but that does not mean that they're a type 1. So many people become confused and think that they're type 2, and once they start insulin, they're now a type 1, and that is not correct. Remember, type 1 would be only if you have these antibodies that usually are present throughout the course of the disease. All right, so how do we treat diabetes? And maybe a better question too is why do we treat type diabetes? So as you're well aware, and I think seems fairly obvious, that high glucose levels are obviously damaging to the body, but they're damaging at a few different levels. So one is that high glucose levels can directly damage physical structures within the body, and this would include things like proteins, collagen, and also vessels, for example, that are housing blood. When we damage proteins, they no longer work as efficiently, so many enzymes and enzyme systems don't work the way they're supposed to. When the glucose binds to and damages collagen, which is one of the fundamental structures underneath our skin, we see that we know that diabetics physically tend to age quicker than non-diabetics, and we think that is because their collagen is being damaged, and therefore they're more prone to things like wrinkling that may not necessarily be medically harmful, but certainly maybe is not what everyone wants. But in terms of the blood vessels, we really break that down into two categories. Small vessels are what we call microvascular disease, and large vessels, which we call macrovascular disease. So the small vessels that can become damaged mainly seem to have problems in the eyes, the kidneys, and the nerves. We call that retinopathy, nephropathy, and neuropathy. And so we screen for damage to these organs, if you will, on a regular basis. So if you have diabetes or know someone that does, they should be having an eye exam at the time of diagnosis and every single year after that. And that eye doctor should know that they have diabetes, and they should be dilating their eyes to look for vascular damage or in the back of the eye or in the retina. At the same time, at least once a year, the kidneys should be screened for damage. We do this in two ways. One is through a blood test, and the other is through a urine test. In the urine test, we're looking for protein. Protein is a sign of stress on the kidney, and is actually the first indicator that the kidneys may be under stress from the high blood sugar. And then last but not least, over time, usually many years, nerve damage can occur. And this typically presents with bilateral symptoms in the feet, and usually in the form of tingling, maybe pain or pressure sensation, but it can lead to both pain and also to a loss of sensation. Once the feet become numb, then someone is much more prone to infection because they may traumatize their foot, walking around barefoot or hitting their toe on the couch and creating a laceration or an injury, and the patient doesn't feel that injury like we would otherwise normally feel, and an infection can develop that can be very serious. So as many of you know, there's a correlation with diabetes and amputation, and part of the reason that amputation occurs is not just because somebody has diabetes alone, but because they have nerve impairment, and they're much more prone to injuring themselves and not knowing it and not taking care of it like you would if you were having pain. Oh, sorry, go back real quick. Thank you. So if we then look at the large vessels, or what we call macrovascular disease, we really are talking about the big vessels that supply the heart, the big vessels that supply the brain, or the bigger vessels that supply blood flow to the extremities, upper and lower. And so we think about this in the form of heart attacks, strokes, and peripheral vascular disease, we call it, respectively. So diabetes increases your risk for all three of these conditions, anywhere from 3 to 10-fold, depending on the study. And so it's important that your provider and that you take every action you can to protect yourself from these obviously impairing conditions. And the way we do that is, one, we obviously control your blood sugar, and two, we also help treat you for other risk factors that would lead to things like heart attack and stroke. Namely, we would control your blood pressure aggressively, we would control your cholesterol aggressively, and any other factors that might be involved with those conditions. But those would be the two most important. Other things like smoking, it's very critical that diabetics do not smoke, because the combination of diabetes and smoking greatly increases the risk for these conditions. And then we also might be a little more aggressive in screening the heart to make sure that someone is not developing abnormally high amounts of plaque and are pending a heart attack that we could otherwise treat or prevent. Last but not least, the high blood sugar can cause cellular damage at the cellular level, really throughout the body. And that would include places in the brain and so forth. So we do know, unfortunately, that diabetics have higher rates of inflammation, they have lower rates of vitamin D, they have higher rates of cancer, and they have higher rates of dementia. And for the most part, we think that a lot of this is due to the hyperglycemia and the insulin resistance. So the more we can do to treat the blood sugar and the insulin resistance, the better off a patient will be and the less likely they are to have any of these problems. All right, so what causes diabetes? Why are we seeing such an increase here in the US? Well, the real answer is for type 1 diabetes, we don't really know for sure, but we think that it's a combination of some environmental exposure, maybe different viruses or other proteins that trigger someone's immune system to make antibodies against that invader. But it turns out that those antibodies also look very much like the pancreas. And so these antibodies then turn their attention to the pancreas and begin to attack it. So classically, type 1 diabetes may occur a few weeks to a few months after a cold or an infection, in which can trigger the immune system again to then begin attacking the pancreas. Because this is multifactorial, it depends on a given individual, what their genetics are around their immune system, which is how they make antibodies and to what they make antibodies to, as well as to their environmental exposures. It's impossible to predict who's going to get type 1 diabetes and who is not. And while it is true that people with type 1 diabetes in their family are more likely to have children with type 1 diabetes, a type 1 diabetic parent is, the odds are that their children will not develop type 1 diabetes overall. So the children are at higher risk, but they're still most likely not going to get type 1 diabetes. And that's because they may or may not come into contact with that environmental trigger, or their immune system is slightly different than their parents, because of course their immune system is made up of genes from both mom and from dad. And it's also important to know that while diet and exercise can certainly help lead to better control in type 1 diabetes and help insulin regimens work more effectively, it is really not the primary way we treat type 1 diabetes. Type 1 diabetes is mainly treated through insulin therapy, and then we get a little bit of benefit with better diet and exercise. If we then compare that to type 2 diabetes, we see that while genetics still play a role, it's not as important or not as aggressive, if you will, as in type 1 diabetes. And there are many, many factors that play a role. And we probably see here that environment probably plays a larger role than it does in type 1 diabetes. So in environment there, we're not talking so much about triggers, but we're really talking about lifestyle, right? So a lack of exercise, a lack of a good healthy diet, probably increased carbohydrate intake and increased sugar intake, all lead to the development of insulin resistance. And there's still a lot of argument as to how much of each of those factors plays a role. And we certainly know that genetics still play a role. So type 2 diabetes is more common in Hispanic populations, in South American populations, in Asian populations than compared to Caucasian populations, and also the African American community as well. We know that if you do the right things in terms of your lifestyle, some people can avoid developing type 1 diabetes, even if they have it in their family. So we think that diet and exercise are really stronger contributors to both the prevention and the treatment of type 2 diabetes than with type 1 diabetes. Finally, we also know that in first world countries, there's been a great increase over the last 200 years in type 2 diabetes. And so we think it's very much related not only to the amount of activity that we do as we become more successful and have more technology, we tend to be less active, but also our diets, and that we, first world countries definitely have a much higher intake of refined carbohydrates like sugar and flour than in third world countries where they eat more whole foods. So we know that that probably plays a role as well. All right, so we're going to talk just a little bit more about exercise, and I kind of mentioned some of this earlier, diet and exercise, that is, because people often have many, many questions about that. Sadly, even after, really studying type 1 and 2 diabetes now for over 50 years, it's been almost 100 years since we've developed insulin and isolated that and been able to make that for people. We still don't actually know exactly what the best diet program is or what exercise is absolutely necessary to prevent or treat diabetes. So unfortunately, you're going to see a lot of differing opinions on this, even within the medical community. At the same time, too, the ADA says that there's really no predefined macronutrient ratio, i.e., should you eat more carbs? Should you eat more fat? Should you eat more protein? The truth is that the studies are very mixed on this. And so as of right now, at least, there is no official recommendation on what percentages a person should eat. And the reality probably is that it probably differs from person to person. And of course, a person's preference differs as well. And we know that whatever diet and exercise program we place someone on, it has to be something that is sustainable to them, or it really is not, it doesn't matter what we prescribe, they're not going to do it, right? So the first thing that we do, and the ADA recommends, is that we individualize our lifestyle changes for a given person, and we work with them to make sure these are things that they're going to sustain. Now, that being said, the ADA has recently shifted their position as of a couple of years ago. Traditionally, for many, many years, they recommended a low-fat, usually higher carbohydrate diet that was in line with the American Heart Association. And in the 80s and 90s and early 2000s, the thought process here is that a low-fat diet would lower heart disease, and heart disease was the number one killer in diabetics, and therefore we should put them on a heart-healthy diet. It turns out, though, that when you eat low-fat, you also eat relatively higher carb. And there's more and more evidence has begun to mount suggesting that higher carb diets actually are worse for diabetes and type 2 diabetes in particular over a longer period of time. And so for that reason, the ADA has kind of restructured their position a little bit and pulled away from a low-fat diet as aggressively. They don't think it's wrong to be low-fat. But what they say is that you really should try to work on reducing your total carbohydrate intake. And the way that you can do that is a couple things. One is obviously you can avoid refined carbohydrates like flour and sugar. You can also increase your non-starchy vegetable intake. These will be basically all of your major vegetables that aren't things like potatoes and rice and beans, all of which are really more starch than they are a true vegetable. But we're talking about things here like some root vegetables with high fiber, like carrots, as well as things like tomatoes, avocado, broccoli, cauliflower, spinach, asparagus. Most of your green vegetables would be obviously in your non-starchy realm. And remember that when you do that, you're also getting very high amounts of fiber, which has been also associated with better blood sugar control and probably better health in general. And then they also recommend really choosing whole foods over processed foods. Now, this is really the same concept. If you think about it, most processed foods are very low in fiber. That's somewhat the definition of processing. And they're usually fairly high in refined carbohydrates, whereas whole foods tend to have the fiber naturally in them. So all the fruits and vegetables that I was talking about all have fiber, and all those carbohydrates that are in those kind of products in nature, that is, the carbohydrate is actually wrapped in fiber. And so our body has to work to get at that sugar. And that means that we have a much slower absorption, which is much more natural to our system. And then last but not least, there's a lot of confusion about alcohol within the diabetic body. It turns out that alcohol itself does not increase blood sugar very much, if at all. And in some patients, it will actually lower their blood sugar after consumption. But it's not so much the alcohol that is the problem right away. It's really what we drink with the alcohol. So there aren't many people that drink straight ethanol, and I probably wouldn't recommend that. It probably tastes pretty terrible on top of the other side effects you're going to get. But, when you have a margarita, you have some tequila there, but you have lots of sugar in that margarita. And so your blood sugar is actually going to spike, not from the alcohol in the margarita, but actually all the sugar in the margarita. So that being said, long-term ethanol intake, if you're drinking daily and frequently and too much, it can actually raise your blood sugar in the morning by having an impact on the liver, but it's not a direct impact. So if you were to say have a shot of tequila, it will likely not raise your blood sugar at all. And it may actually suppress your blood sugar, as I mentioned, overnight. And so diabetics do need to be careful about low blood sugars overnight, especially if they've been drinking heavily the evening before. In terms of exercise, again, we're going to see a lot of different recommendations. I think a couple of things are key to keep in mind. One is that if you're not exercising regularly, it's really important that you do something you like, something you're going to sustain, and that you really start slow, move steady, and stay in the game. And that means don't get injured. If we have good intentions, but we're too aggressive with those intentions, you're going to go out there, get really sore, and not want to go back and do it, or you're going to get injured and not be able to sustain it over time. So just remember here that Rome wasn't built in a day, and you should take your time and become more active. And in some of the bigger trials that we have, like the DPP trial, Diabetes Prevention Program trial, they did things that were very simple, like had people walk, 3 to 4 times a week. So this doesn't have to be really strenuous or painful exercise. It can be something very, very simple. Simple walking is a great way to get started, or any other low impact exercise that you enjoy. And that's all you need to get the insulin resistance broken and to begin to reverse the type 2 diabetes process. And I think a good goal in general then is to move often, probably about 30 minutes, 5 times a week is the ultimate goal, but you don't have to start there. You could easily start with 2 or 3 times a week and maybe 20 minutes, but try to build to that 30 minutes, 5 times a week over maybe a longer period of 6 to 12 months. And in terms of weight loss, one thing to keep in mind is that while weight loss generally improves type 2 diabetes, it is not always the case. But that being said, we do recommend some weight loss, and we typically shoot for a total weight loss of about 7 to 10%. And that has been shown to have a clinically important impact on blood sugar. So 7 to 10% for most people is somewhere around 15 to 20 pounds. And, if you think about it, depending on your weight, that may not be your ideal body weight, but it doesn't matter. The studies really show that that's all you need to have an impact. So I think having a reasonable goal with yourself is important, at least when you get started. And then if you get to that 10% weight loss and you still have more to go and you're motivated to do so, then that's absolutely fabulous. Keep going and try to achieve more. But this is a good initial goal to set. All right, so what happens when our lifestyle is just not enough? So there are many different families of drugs within type 2 diabetes, and I'm speaking here really about type 2 diabetes. But I wanted to highlight a few because the guidelines in the last few years have really become, I think, much more clear that these 3 families of drugs are preferred families of drugs that we should use. There are some other ones out there, they do work, and some of the other ones are older and a little less expensive, so we always have to consider cost. But these 3 families have clearly shown benefit over the others. So first and foremost is metformin, which many of you have probably heard of. Metformin is still considered our first-line therapy and has been such since 1995, since it was released here in the US, although it's been on the market in Europe for many decades prior to that. So we now have data almost 50 years out looking back at metformin, and we know that it is safe, effective, it does not create low blood sugars, it does not cause weight gain, and it's usually our initial medication to consider for type 2 diabetes. It's important to know that some people will get some GI-related symptoms like diarrhea with metformin, and changing to a different preparation or a lower dose may make those symptoms go away and make them tolerable. And I would just encourage you that if you are having symptoms from metformin, definitely have that discussion with your provider, because there are other ways that we can get around that or other options that we can use. And if you don't tolerate metformin, even though it is first-line therapy, know that you don't have to use it. We can use other drugs besides metformin. And I think sometimes providers are a little reluctant to stop it, but the reality is there are other good options here that I'll discuss. Last but not least, recently on the web, we've seen a lot of people coming in asking questions about whether or not metformin is dangerous, or maybe that it's been pulled from the market. That is not true. So metformin is definitely safe and not dangerous. Where that is coming from, by the way, is many of our generic drugs are being manufactured now in other countries, such as China, for example, and there have been contamination issues with certain generic drugs. And when those recalls happen, your pharmacist should let you know. So you do not need to stop your medications if you're having, if there are recalls that you've heard about online. You need to contact your pharmacist first and find out if your medicine was affected. And if it was not effective, then you definitely want to continue your medications. The other two families I'm going to mention here, and I've listed them for you just for your reference, are two families that have been on the market for about 15 and 10 years respectively. The first are what we call the GLP-1 inhibitors. You can see the names listed there, and these are the common trade names. Right now, they're not generic, and they can be expensive, but it really depends on the coverage of your plan. And these are injectable medications, although there is one oral medication now, version of this called Rybelsus. And what they do is they help the beta cells work more efficiently to make insulin in a more natural and more robust way. They also slow digestion, and they increase your sense of fullness. And so this ultimately leads to not only good blood sugar control without low blood sugars, but also weight loss, improved blood pressure, and in addition to that, and improved cholesterol as well. But in addition to that, we now know through many different studies that have been done that they also reduce heart attack and stroke rate, and they also probably improve kidney performance over time, or they reduce the risk of kidney injury. And so for that reason, these medicines are now considered second-line therapy behind metformin in most of the guidelines. The final family I mentioned here is called the SGLT2 inhibitors. And these are oral medications that you take once a day that work on your kidney to help your kidney release glucose from the body. And again, like the GLP-1s, they also promote weight loss. They do not cause low blood sugars, and they are also known to lower both blood pressure and triglycerides as well. So very similar. Now, they work by different mechanisms, and you can use these in combination. Matter of fact, this combination works very well together, but they each do all these benefits independent of each other. We also know now through multiple large trials that they improve the rates of kidney dysfunction. So kidney patients probably should be on these medications that have type 2 diabetes. And if someone is just concerned about preventing kidney injury or kidney failure over time, they should start these medications probably earlier in the course of treatment. And they're also very effective for heart failure and also heart attacks as well, but probably more effective in heart failure than in prevention of heart attacks or heart disease. So for those reasons, this is also listed as a second-line therapy behind metformin. And so again, these top three families, if you will, should really be considered in most type 2 diabetics. And I would just encourage you to have a conversation with your provider if you are not on these medicines, but we're interested in them so they can give you more information. All right, so what are our goals if we have diabetes? What do we want to achieve here? So we want to really normalize blood sugar as much as possible. And what we're trying to do in normalizing blood pressure, our blood sugar, of course, is we're trying to avoid the complications of type 2 diabetes, i.e. damage to the small vessels and the large vessels. So our goals typically are to keep your hemoglobin A1C less than 6.5. That is considered very well controlled. Now, if patients get older or have other limited life expectancy, we may raise that number to a higher number. But for younger, healthier patients, 6.5 is a more aggressive but appropriate target. We also would like to see your fasting blood sugar down around 100. The ADA uses 110. The endocrine guidelines use less than 100, but somewhere around 100 or less is a good goal. And then if you really are being aggressive, a great goal is if you want to check your sugar 2 hours after you eat, if that blood sugar is staying under 140, that means you're eating right and that your medications are working well if you're on them. And that's a very aggressive but good goal. And typically, if you can achieve a fasting glucose of less than 100 and a 2-hour post-meal glucose less than 140, you will not only have an A1C less than 6.5, but probably less than 6.0, which is very, very good and is a great thing to shoot for. Of course, as I mentioned earlier, we also want to make sure that patients don't develop heart disease or stroke. And so we try to control their blood pressure fairly aggressively, as well as their cholesterol. So many diabetics will go on cholesterol medications when they're diagnosed with diabetes. And they might wonder, well, is my cholesterol all of a sudden worse than it was last year? And the answer is no, it's not. It's that the goalpost has shifted. We now are more aggressive than we would have been otherwise if you have diabetes. And only about 5% of patients will have an LDL cholesterol under 100 naturally. And LDL cholesterol, by the way, or so-called bad cholesterol, is not as dependent on the diet as the other components. So patients will also often say, hey, my LDL cholesterol is 140. Can I just work on my diet and see if I can avoid taking medicine? And the real answer is, yeah, you can absolutely work on your diet, maybe reverse your diabetes. but you probably aren't going to be able to get your LDL under 100 without medication. And so that's a discussion you should have with your provider. But most diabetics are wise to be on cholesterol medications to reduce their risk for a heart attack and stroke. And then last but not least, of course, is, take care of your body. And so we talked about weight loss, and also remember that things like, regular foot exams at least once a year are important, making sure that you haven't developed any numbness in the feet. At the same time, making sure that you're wearing proper shoe wear, and having your providers also look at your feet as well. How about testing your blood sugars? So, there are many different ways to do that now, which is great. But it turns out that many type 2 diabetics, particularly if you're on the 3 families I mentioned that don't create low blood sugars, there's really not a lot of reason why you have to do that. So if you want to do that, great, but don't feel like you have to. I always tell people it's more important that you take your medicines and keep your visits with your provider than to put a whole bunch of effort into testing your blood sugar and then forgetting to do those other 2 things. That being said, anytime somebody feels that the blood sugar may be low, I think it's important that they check to verify whether or not that's happening. And of course, if it is, which we define as a blood sugar of less than 70, we encourage you to follow up with your provider and let them know so they can make adjustments. In addition to that, also realize that many diabetics have been told, or there's a myth out there, that they need to eat on a regular basis to avoid low blood sugars. But it turns out that that really rarely happens. And that it's not necessary to eat constantly to keep blood sugars from going low. Most of that advice came from the years past when we had to use medications that created lots of hypoglycemia or low blood sugars. Also, many patients get in the habit of testing in the morning, but the reality is that it's also good to know what happens after meals, as I mentioned earlier, to give you feedback on how your blood sugars, responding to the things that you're eating. So I encourage patients at a minimum to test in the morning, but also about 2 to 3 hours after dinner, maybe at bedtime, so they get an idea of both the highs and the lows of the day. And of course, I don't think that they have to do this every single day. If patients are on insulin, it is important to probably test 3 or 4 times a day. But for non-insulin patients, doing a morning and an evening test a few times a week is likely adequate. Last but not least, there are new monitors on the market you may be aware of. They're called continuous glucose monitors, or what we call flash glucose monitors. There's the 2 most common devices are the Dexcom G6 and the Freestyle Libre. And these are devices that you can wear for about 7 to 14 days on your skin. They're small little devices about the size of a quarter that you attach and will stay on you. And you can use your phone or you can use a scanner, and you can scan the device, basically hold it close, and it'll tell you your blood sugar anytime you'd like to know. In addition to that, the Dexcom actually is an active monitoring device that will feed back to your phone. So you can look at your phone, or if you have a smartwatch, it can actually feed back to that. And you can see your blood sugar in real time on your watch, which is pretty incredible. So these are all devices that your providers should be familiar with and can help you get if you're interested. Next slide. All right, there we go. So I didn't list a lot of resources here for you today. Really, I think the ADA has a great compilation that's very easy to understand. And so I just listed here for you the ADA's website if you'd like to check that out. And they have tons of information on both type 1 and type 2 diabetes. So with that, I'd like to say thank you for your time. I hope that this information was helpful. And we're going to pause now to take some questions from the audience.